We put a lot of trust in medical implants, don't we? Sort of think of them as these permanent fixes.
Yeah,
But
absolutely.
what if those very solutions carried, a hidden risk, a potential for serious infection that could just undo all the good work?
Mm-hmm.
That's exactly what we're diving into today, this
Yep.
tricky world of infections in implanted vascular grafts.
Exactly. And we're going to be using insights from Rutherford's Vascular Surgery and Endovascular Therapy, the 10th edition, as our guide here.
Okay.
Think of this as your shortcut, maybe, to understanding why these infections happen, how doctors figure them out, and, well, the surprisingly complex ways they're treated.
Right. So for anyone who hasn't maybe encountered this directly, a vascular graft is essentially like an artificial blood vessel.
That's right.
Doctors use them to bypass blockages or repair damaged arteries and veins. A real game changer for getting blood flow back.
Oh, they are indeed a total game changer. But, introducing any foreign material into the body, it presents a challenge for our immune system. Grafts are no exception. Now, the initial risk of infection, it might seem low, maybe somewhere between 0.2% and 5% for open surgeries.
Okay, that doesn't sound too bad initially.
Right. But here's the crucial point. If a graft does get infected, the consequences can be, well, absolutely devastating.
Catastrophic is the word. So, okay, let's get into the nitty-gritty. How do these infections actually take hold? What's the process?
Well, the simple presence of a foreign object like the graft, it just makes the body much more vulnerable to infection. Remember that classic study on sutures? It showed that even like a single strand of thread dramatically reduced the number of bacteria needed to cause a problem.
Right.
So with a larger graft, that susceptibility is just amplified. The key takeaway here is really that even a small amount of foreign material drastically lowers the body's defense against infection.
That's a really clear way to put it. It's like the graft lowers the bar for infection.
Exactly.
So what are the main ways these bugs actually get in there?
There are four main pathways, generally speaking. First, perioperative contamination.
Okay, during surgery.
Basically, yeah. Direct contact during the surgery. It could be from the patient's own skin, especially in areas like the groin, which naturally have more bacteria.
Right.
It could also happen through the surgical wound itself, or even from an infection somewhere else in the body that travels, maybe through the blood or lymph to the graft site. Things like emergency surgeries, connecting the graft to the femoral artery down in the groin, creating subcutaneous tunnels for the graft, repeat operations, longer surgery times. They all increase this risk.
Okay.
And interestingly, even the walls of diseased arteries themselves or reoperative wounds, they can harbor bacteria, often Staphylococcus.
So even the patient's own body can be a source of trouble. That's a bit unsettling. What's the second way?
The second is bacteremia. That's when bacteria are actually circulating in the bloodstream and then they sort of settle on the graft.
Okay. From somewhere else entirely.
Exactly. This can come from seemingly unrelated infections like IV catheter infections, UTIs, pneumonia, or even, say, foot wounds. Now, while the risk does go down as the graft integrates with the surrounding tissue over time, it's still possible even a year or more later. Sometimes, even routine things like dental work or colonoscopies can release bacteria into the bloodstream temporarily, and that could potentially lead to a late graft infection. That long-term vulnerability is definitely something you need to keep in mind.
Absolutely. Okay, what about the third way?
The third is mechanical erosion. This mainly applies to aortic grafts, the ones in the main artery, which pulse with each heartbeat, right?
Right, constantly moving.
Exactly. Over time, this movement can cause the graft to sort of rub against nearby organs, especially the bowel.
Oh, boy.
Yeah. Eventually, it can wear right through the bowel wall, creating what's called a graft-enteric erosion, or fistula. We often call it GEE or GEF.
GEF.
Okay. And while sometimes there's no obvious infection beforehand, a sort of low-grade infection of the graft, often with staph bacteria causing inflammation, can make the bowel more likely to stick to the graft and then erode.
So the infection might actually contribute to the erosion itself.
It can, yeah. It's a really serious complication. Happens in about 0.4% to 2% of patients after aortic grafting. And erosion can also happen through the skin, too, not just into the bowel.
That sounds like a very direct and dangerous route. And the final mechanism.
The fourth is contiguous infection. This is where an infection spreads from a nearby infected area to involve the graft.
Like it spills over.
Pretty much. For example, diverticulitis, an infection in the colon, could spread and affect an aortofemoral graft. or maybe an infected lymphocele, a collection of lymphatic fluid, could affect a peripheral graft in the leg.
Mm.
So it's not always a direct hit on the graft itself, but, surrounding trouble can spill over.
Okay, so we know how the bacteria can get there, but
Mm-hmm.
are there things that make some people more likely to get these infections than others?
Oh, absolutely. The
Yeah.
patient's overall health and, well, the strength of their immune system play a huge role.
Makes sense.
Conditions like malnutrition, cancer, autoimmune diseases, chronic kidney disease, advanced liver disease, medications that suppress immunity like corticosteroids, chemotherapy, they can all increase the risk. Even if the initial number of bacteria is small,
Right.
there might also be a connection with diabetes. So yeah, overall health and immune function are crucial.
Okay. Now, let's get a bit more technical for a second. What actually happens at a cellular level once the bacteria arrive? What's going on down there?
Right. It's a pretty complex chain of events. First, the bacteria, they need to attach to the graft surface.
Okay.
Interestingly, they seem to stick much more easily to polyester grafts like Dacron compared to PTFE grafts.
Oh, why is that?
Well, gram-positive bacteria, like staph, they produce this sticky outer layer, we call it glycocalyx or mucin, which helps them cling to the graft better than gram-negative bacteria can.
Like glue.
Sort of, yeah.
Oh.
And specific molecules on Staphylococcus also help them attach. Once they're on the surface, they form these little communities, microcolonies, and start building a biofilm.
Ah, the biofilm. We hear a lot about that.
Yes, it's basically a slimy protective shield that makes it much harder for the body's immune system and, importantly, antibiotics to actually reach them.
Right, it hides them.
Exactly. This bacterial presence then triggers the body's defense mechanisms. Immune cells called neutrophils arrive. The complement system gets activated.
The cavalry comes in.
Right. But this, in turn, causes inflammation in the tissues around the graft and where it's sewn to the artery, the anastomosis.
So the body tries to fight back, but that biofilm acts like a fortress.
Mm-hmm.
What about the healing process itself? Does the infection mess with that?
It definitely can. Normally, the body tries to incorporate the graft-growing connective tissue into its outer surface.
Okay.
However, if fluid or blood clots, seromas, or hematomas collect around the graft early on, this can interfere with that process. It gives bacteria more places to stick and grow.
Wow.
And the inflammation itself can create a difficult environment for healing. It might reduce blood flow, make the area more acidic, and an imbalance in certain inflammatory substances can lead to the body producing too many matrix metalloproteinases, or MMPs.
MMPs.
Yeah, these are enzymes the body releases during inflammation. In excess, they can actually hinder healing around the graft by breaking down the building blocks needed for tissue repair.
So they work against the healing.
In this context, yes. Without good tissue ingrowth and blood supply around the graft, it's more exposed to bacteria. They can then hide in the graft's tiny pores, sort of out of reach of immune cells. Even the neutrophils that do arrive can have their function impaired by the graft materials themselves.
Wow. It sounds like a real vicious cycle. Inflammation hinders healing, which makes it easier for bacteria, which causes more inflammation.
That's a good way to put it. It can be, yes.
Now, who are the usual suspects when it comes to these infections? Which bacteria are we talking about most often?
Staphylococcus aureus is definitely the most common culprit. It causes maybe 25% to 50% of graft infections, depending on the location.
Okay. Staphylococcus aureus.
But we are seeing more and more infections caused by Staphylococcus epidermidis, another type of staph, and also gram-negative bacteria.
Why the shift?
Well, it partly reflects that we're just better now at diagnosing both early and late infections, including those aortic graft infections related to GSHF we talked about.
Ah, okay.
And S. epidermidis, while it's normally found on our skin and usually less aggressive,
Yeah.
it's very good at sticking to medical devices and forming those protective biofilms.
Right, the biofilm specialist.
Pretty much. So the crucial insight is this shift towards these biofilm-forming bacteria like S. epidermidis. They can be much harder to detect and treat. And it's also worth knowing that in these late infections, the number of bacteria in the biofilm can actually be quite low, and they can grow very slowly. That makes them difficult to culture in the lab sometimes.
So a negative culture doesn't always mean no infection.
Exactly. In fact, some graft infections where cultures come back negative are actually due to S. epidermidis or other similar bacteria, maybe even sometimes fungi like Candida. So yeah, not all infections present with obvious teeming colonies of bacteria.
Okay. What about the more aggressive types of bacteria, the nastier ones?
Right. Gram-negative bacteria, things like E. coli, Pseudomonas, Klebsiella, Serratia, Proteus. They can be particularly dangerous.
Why is that?
They produce strong toxins, endotoxins, that can severely damage the wall of the blood vessel where the graft is attached. This leads to a high risk of the graft detaching, what we call anastomotic dehiscence, and even the artery rupturing.
Yikes. That sounds incredibly dangerous.
It is. Fungal infections like Candida and Aspergillus and mycobacterial infections like TB, those are rare and usually happen in patients with very weakened immune systems or who have pre-existing fungal or other opportunistic infections.
Okay. And we can't really talk about bacteria these days without mentioning antibiotic resistance, can we? How big of a problem is that with graft infections?
It's a major and unfortunately growing concern. Staphylococcus aureus, the main culprit, has become resistant to many common antibiotics.
MRSA.
Exactly. Methicillin-resistant Staphylococcus aureus, MRSA. It's become much more common both in hospitals and out in the community over the last decade or so. Studies have shown that people in long-term care facilities have a higher rate of MRSA colonization, and even some patients coming in for surgery are unknowingly carrying MRSA. So the combination of its increasing prevalence, its presence in vulnerable people, the various ways it can cause harm, and its, evolving resistance to antibiotics. It makes MRSA a really serious medical challenge.
Yeah.
British reports suggest MRSA is now the most common bacteria found in vascular wound and graft infections there, and it's linked to higher rates of illness and death.
And here.
Well, our own experience at the University of South Florida, we saw a 4-fold increase in MRSA arterial graft infections over a 25-year period.
A 4-fold increase. That's huge.
It is. The concerning insight really is that even seemingly routine surgeries carry this risk now of encountering antibiotic-resistant bacteria.
So did that increase lead to worse outcomes in your study?
Interestingly, in our study, we didn't see a significant increase in early deaths or limb loss specifically because of MRSA compared to other bacteria.
What?
But the potential for just more graft infections overall because of the increasing amount of MRSA in our patient population, that's definitely something we're watching very closely.
That paints a stark picture. Yeah. Early detection is obviously key then, isn't it?
Absolutely critical.
So how do doctors actually spot these infections? What are the clues they look for?
Yeah, early diagnosis is critical to avoid the really serious problems like widespread sepsis or bleeding. But the signs can vary quite a bit, and they can be subtle.
Subtle. How so?
Especially with infections that appear late, months or years after the graft was placed, particularly if the graft is inside the abdomen. For aortic grafts, maybe unexplained fever and just feeling generally unwell, signs of systemic illness. Maybe a blockage of the intestines, what we call an ileus, or abdominal swelling might be the first clues. Now, if the infection involves a graft outside the main body cavity, like in the groin or the leg, then you might see more obvious signs like inflammation or redness of the skin over the graft, maybe a draining sinus tract that's like a small channel oozing a pus, or the development of an anastomotic pseudoaneurysm.
A pseudoaneurysm, like a bulge.
Yeah, a false aneurysm, a contained rupture right at the point where the graft is connected to the artery. And here's a really critical point.
What?
Any patient who has an aortic graft and suddenly develops gastrointestinal bleeding, you have to suspect they have a graft infection and a connection between the graft and the bowel that GG until you prove otherwise, usually with an endoscopy or even surgery.
Wow. That's a must-investigate situation.
Absolutely. Don't ignore GI bleeding in someone with an aortic graft.
Okay. Are there other, maybe more subtle clues we should be aware of?
Yes. In patients who just have vague symptoms, maybe imaging findings that aren't totally clear-cut, a detailed medical history is really important.
What kind of questions?
Doctors will ask about any recent illnesses, anything that might have allowed bacteria to get into the bloodstream or the lymphatic system and potentially settle on the graft,
Right, looking for that bacteremia source.
Exactly. Now, early graft infections, often caused by S. aureus or maybe other gram-negatives, they tend to show up within weeks of the surgery, usually with fever, a high white blood cell count, problems with the surgical wound, maybe pus draining from around the graft.
Pretty clear signs, then.
Often, yes. And if bacteria show up in the bloodstream itself, that's usually a sign of a more advanced infection. It might involve the artery wall, maybe a blood clot on the graft, or even infection spreading to the heart valves, endocarditis.
Okay. And the late ones?
On the other hand, those infections caused by S. epidermidis, the biofilm ones, they often appear years after the graft was put in. Yeah, sometimes with complications like an aneurysm at the graft connection, or fluid collection around the graft, or a sinus tract, but often without the typical signs of widespread infection like fever or high white count.
So they can be much sneakier.
Much sneakier, yeah.
So the timing of the symptoms and the specific signs can give clues about the type of infection. What about lab tests? Are they helpful in diagnosis?
While an elevated white blood cell count, maybe with a higher percentage of immature neutrophils, a left shift, and an increased ESR erythrocyte sedimentation rate, those are common if there's a graft infection and fever.
But not specific, right?
Exactly. They just show inflammation somewhere. They're not specific to graft infections. Routine labs should also include a urine test, definitely blood cultures to try and catch any bacteria in the bloodstream,
Hmm.
and cultures from any other potential infection sites like maybe a foot ulcer or wound drainage.
And do the blood cultures usually pick it up?
Interestingly, no. Blood cultures are often negative, found in less than 5% of cases, actually.
Really, only 5%.
Yeah, but if they are positive, it usually suggests a more advanced or aggressive infection. And here's the important thing to know.
Okay.
All these lab results, white count, ESR, blood cultures, they can be completely normal in patients with those late-appearing S. epidermidis infections around the graft.
So you can have a serious infection with totally normal blood work.
You absolutely can. So we definitely can't rely solely on blood tests.
That makes imaging even more important, I imagine.
Crucial.
What are the key imaging studies that are used to diagnose these infections?
Yeah, vascular imaging is essential, both for diagnosing the graft infection and, critically, for planning how to treat it.
Right.
We can identify anatomical signs like an abscess around the graft, an aneurysm at the connection point, that connection to the bowel, GEGEF. We can spot those with a high degree of accuracy, over 90% sensitivity, usually by using a combination of CT scans and maybe endoscopy.
Okay.
Imaging helps us see exactly where the infection is, how far it extends, identify any related problems like poor wound healing, and it really guides us in planning the surgery.
Let's break down the main imaging techniques then. We hear a lot about CT scans. How are they used in this context?
Okay. Contrast-enhanced CT scans, often combined with CT angiography CTA to visualize the blood vessels, they're usually the preferred first-line imaging.
For which grafts?
For suspected graft infections in the aorta and its major branches, also grafts in the abdomen and chest. And they're helpful for infections in the neck, torso, upper parts of the limbs too.
How they do it.
Ideally, the CT scan should be done both before and after injecting intravenous contrast dye.
Okay.
If we suspect a connection to the bowel, that GOGF, we might also use oral contrast to help see the relationship between the graft and the intestines layer.
Right.
The graft itself, whether it's polyester or PTFE, is actually best seen on the initial images taken without contrast.
Oh, okay.
Then, looking at images taken a little later, after the contrast has filled the arteries, the delayed arterial phase, or maybe using a special bone setting on the early arterial phase images. That helps us clearly separate the graft, the arteries, the veins from all the surrounding tissues. Makes it much easier to interpret the scan.
And what are the key signs of infection that doctors are actually looking for on that CT scan? What are the red flags?
Okay, key signs include a loss of the normal fat planes.
Planes.
Yeah, the thin layers of fat that usually surround these structures in the retroperitoneum, that's the space behind the abdominal cavity or in the tissues under the skin. Losing those fat planes indicates inflammation.
Okay. Makes sense.
We also look for collections of fluid or gas around the graft. And it's really important to know that seeing gas more than, say, 2 to 3 months after the graft was implanted is particularly concerning. It strongly suggests infection.
Right, because any air from surgery should be long gone by then.
Exactly. Also, the formation of those false aneurysms, signs of kidney blockage like hydronephrosis, swelling of the kidney due to urine backup and infection of nearby vertebrae or bone called osteomyelitis, those are also red flags.
Got it.
And the CT angiography part helps us see the blood flow through the arteries, identify any blockages, and plan the surgical repair of the arteries without needing a separate, more invasive arteriogram usually.
So CT gives a really good anatomical picture. What about ultrasound? When is that a useful tool?
Ultrasound is really valuable for quick bedside exams, especially in very sick patients.
Okay.
It's often the first imaging study we'd use for suspected infections of grafts outside the main body cavity, like in the groin or the leg.
And what can it show?
Using color Doppler ultrasound, we can reliably tell the difference between just a simple fluid collection around the graft and an anastomotic pseudoaneurysm, or a hematoma, a collection of blood, or other soft tissue masses like enlarged lymph nodes. Ultrasound is also probably the most accurate way to check if a blood vessel or a graft is still open, if it's patent, and to assess any pulsatile masses near grafts in the groin and limbs.
Okay, and MRI. How does that fit into the diagnostic picture? Is it better than CT sometimes?
Well, MRI provides similar anatomical detail to CT, but it's often better at distinguishing between fluid and scar tissue. It depends on how they appear on different types of MRI images, the T1 and T2 weighted images.
Okay.
Using gadolinium contrast can enhance the visualization of blood vessels in magnetic resonance angiography, or MRA. That can also be used to plan the surgical repair.
But there are issues with gadolinium, right?
There can be, yes. While gadolinium is generally less toxic to the kidneys than the iodine-based contrast used in CT, it has unfortunately been linked to a rare condition, nephrogenic systemic fibrosis, affecting the skin and other tissues in patients with kidney problems. So that's definitely something we need to consider.
Right. Okay, so we've talked about imaging, the structure, the anatomy. Are there ways to actually see if there's active infection using, like, functional image?
Yes, there are. There are imaging techniques that use radioactive tracers to detect active infection. These are often called functional white blood cell scans.
How do they work?
The idea is to take some of the patient's white blood cells, label them with a radioactive substance, inject them back into the bloodstream, and if there's an infection, these labeled cells will accumulate in that area. We can then see that accumulation on a scan.
Clever.
It is. However, these scans don't give us a lot of detailed anatomical information on their own, so they're often used together with CT or MRI to understand the extent of the infection.
Are they accurate?
Different radioactive materials can be used, and their accuracy can vary. Scans using indium-111 labeled white blood cells have pretty good accuracy, maybe 80% to 90% in detecting graft infections. But they aren't very helpful in the early period right after surgery, usually the first 3 to 6 months.
Why not?
Because the normal healing process and just general inflammation can cause the radioactive material to accumulate in the area, even if there's no actual infection. That leads to false positives. And unfortunately, these scans can also miss infections sometimes. They can show no abnormal white blood cell accumulation, even when there is an infection, false negatives, particularly in those late-appearing aortic graft infections and in confirmed cases of GGEF.
So useful sometimes, but not foolproof.
Exactly, not foolproof.
It sounds like each imaging technique really has its own strengths and weaknesses then.
Definitely. You often need to put the pieces together.
What about looking directly at a potential problem area? When is endoscopy used?
Upper endoscopy is really crucial, a key diagnostic tool, when we suspect that graft enteric erosion or fistula, the GGF.
Right, the connection to the bowel.
Exactly. It allows the doctor to directly look at the lining of the esophagus, the stomach, the entire duodenum, that's the first part of the small intestine, and ideally the beginning of the jejunum, the second part, to look for any signs of bleeding or a direct connection to the graft. Sometimes we might even use a smaller colonoscope, like one designed for children, just to get a more thorough look further down.
Okay. And what about getting a sample directly from the area of concern? Can you stick a needle in?
Yeah, taking a sample of fluid collections around the graft using a CT-guided needle aspiration. That's becoming more common. Trying to figure out if it's just a sterile fluid collection, a seroma, or if it's an actual abscess, which indicates infection.
Makes sense.
However, there's always a risk of not getting a representative sample, especially if the fluid collection is complex, maybe divided into multiple compartments.
Right.
And also, just because the culture from that aspirated fluid comes back negative doesn't always mean there isn't a low-grade biofilm infection lurking, like one caused by S. epidermidis.
Back to the sneaky biofilms.
Exactly. Ultimately, the most definitive way to diagnose a suspected graft infection is often to surgically explore the area.
Go in and look.
Yeah, especially when the imaging results aren't clear or if we strongly suspect a GGEF. Directly seeing the outer surface of the graft during surgery can help us identify those late, slow-growing biofilm infections, particularly on polyester grafts, which tend to get surrounded by a thick layer of scar tissue.
Okay. So when they do go in surgically, or if they get a sample, how do they determine exactly what's causing the infection? How do they culture it properly?
Right. Standard swabs taken from the surface of the graft and any surrounding fluid are usually sufficient for the more obvious infections, the ones caused by aggressive bacteria that are present in large numbers.
Okay.
However, surface swabs might miss bacteria that are less aggressive, maybe haven't deeply invaded the surrounding tissues, and also if A gram stain of tissue or fluid from around a graft that's maybe come loose doesn't show any bacteria,
Yeah.
but it does show white blood cells. That's not enough to rule out a low-grade infection. There could still be small numbers of slow-growing bacteria living in a biofilm.
So how do you find them?
For a more reliable way to identify the bacteria within a biofilm, the removed piece of graft, the explanted graft segment, it needs to be physically broken up.
Broke it up.
Yeah, either by grinding the tissue or using ultrasound sonication before it's placed in a liquid broth culture medium.
Why broth?
Well, putting a small piece of the graft directly into a broth medium is thought to be the best way to encourage any attached bacteria to grow. The liquid completely covers the graft, provides better access to nutrients.
Oh, okay.
This technique is particularly helpful for confirming those tricky S. epidermidis infections, and it's also really important that the culture tubes are kept incubated for maybe 5 to 7 days.
Longer than usual.
Yeah, to allow enough time for any slow-growing organisms to actually be detected.
Okay, we've covered how these infections happen, how they're diagnosed in quite some detail. Now, for the really critical part, what can actually be done to treat them? What are the treatment options available?
Right. The main goals of treatment are, 1, get rid of the infection completely, both locally and systemically, short and long term. And 2, make sure there's still enough blood flow to the affected organs and limbs.
Eradicate infection, maintain perfusion.
Exactly. Our team at USF, we take a pretty personalized approach. We consider standard methods like completely removing the infected graft and creating a new bypass somewhere else, or replacing the graft in its original location, in situ when that's appropriate, and sometimes even trying to preserve the original graft, but only in very specific situations.
Okay.
So it's definitely not a one-size-fits-all approach.
What are the main factors then that help decide which treatment is best for a particular patient?
The decision really depends on how the patient is presenting clinically, how much of the graft is actually infected, and crucially, what type of bacteria we identify.
Yeah.
There are also important additional treatments, adjuncts, that help us sterilize the wound. These are especially key when we're thinking about replacing the graft in the same spot or trying to save the original graft.
Like what?
Things like multiple surgeries just to clean the wound, aggressively removing any infected artery wall and surrounding tissue, washing the area out during surgery with antibacterial solutions, temporarily placing those beads loaded with antibiotics we mentioned, covering the repaired arteries with healthy muscle or other tissue flaps, maybe using negative pressure wound therapy.
A wound vac.
Right. Sometimes placing drains that continuously rinse heavily infected areas with antibiotic solution, and of course giving intravenous antibiotics that are specifically targeted to the bacteria we find.
Wow, that sounds like a very comprehensive, multi-pronged strategy.
It often has to be.
Are there any general rules or principles that are always followed when treating these infections?
Yes. I'd say a key principle is that infections involving artificial graft materials, prosthetics, often require at least partial and usually complete removal of the graft to effectively eliminate the infection.
So getting the foreign material out is usually necessary.
Usually, yes. Trying to save the original graft, preservation, is really only a good idea in very specific limited situations.
When might that be?
Graft preservation is more likely to work when the infection involves the patient's own tissues that were used for reconstruction, like maybe vein bypasses or vein patches.
Okay.
At USF, we've had some success with preserving prosthetic grafts in infections that appear early after surgery and are located outside the main body cavity, like in the groin. Overall, we've actually seen similar outcomes in terms of mortality and limb loss in both early and late infections when we use a carefully chosen treatment plan based on these principles.
That's good to hear.
However, for severe infections, the ones with systemic sepsis, caused by aggressive gram-negative bacteria like Pseudomonas, Klebsiella, Serratia, Proteus, E. coli, removing the graft and creating a new bypass somewhere else, extra anatomic bypass, is usually necessary.
Right.
And infections of grafts inside the main body cavities, the chest or abdomen, they're much less likely to be successfully treated with just repeated cleaning surgeries alone.
Why is that?
The risks are higher in there. These usually require a more definitive procedure, either a 1 or 2 stage operation involving complete removal and replacement of the graft. Because there are increased risks with repeated surgeries in the abdomen or chest, including the risk of the graft rupturing or the infected graft eroding into the bowel, trying to preserve the graft in those situations is rarely the right approach.
Okay.
We actually have a suggested treatment plan, an algorithm for these infections inside the body that takes into account various clinical and anatomical factors.
Let's delve into the specifics of the treatment approaches then. First, graft preservation. You said it's limited, but when is it an option? And what exactly does it involve?
Okay. Trying to save the existing graft preservation, it's only really a possibility in a small number of cases. The ideal patient has a graft that's still open, patent, with only a short segment that's infected, and crucially, it doesn't involve the areas where the graft is sewn to the arteries, the anastomoses. It tends to work better with PTFE grafts than polyester ones, better in infections that show up early, say, within 4 months of implantation rather than late.
Right.
When the infection is caused by a single type of gram-positive bacteria, not multiple types or gram-negatives, and when the infection is located outside the main body cavity.
So lots of conditions.
Lots of conditions. The infection should also be pretty localized, confined to the immediate area around the graft, caused by bacteria that aren't super aggressive and not associated with systemic sepsis.
Got it. And the steps.
The steps involve repeated surgical cleaning of the wound, debridement, using antibacterial solutions to wash the area, irrigation, and placing those PMMA beads, polymethyl methacrylate, loaded with antibiotics in the wound to really knock down the bacterial count.
Okay.
Ultimately, we need to see negative cultures from the wound before we can safely cover the exposed part of the graft with healthy, well-supplied muscle tissue or close the skin over it.
And how successful is it?
Well, while some centers have reported success in preserving grafts in a higher percentage of patients with early groin or lower leg bypass infections, we've found that if the local infection persists despite these treatments, removing the graft is usually necessary in the end. Using our stricter criteria at USF, only a small proportion of patients, maybe 15% to 20%, with early infections outside the main cavities were really good candidates for preservation. But those who were successfully treated this way.
Okay, so preservation is definitely for a select few. What about the more common approach then? Removing the infected graft. What happens after that?
Right. When the infected graft is removed, we often need to restore blood flow through a new pathway using what's called an extra anatomic bypass.
Meaning
we create a new bypass graft in a clean part of the body, totally away from the infected area.
Okay.
However, in some situations, if the infected graft has already clotted off, maybe it wasn't working anyway, and the limb has enough blood supply through other arteries, the collaterals, we might be able to just remove the infected graft without immediately placing a new bypass.
The body compensates.
Sometimes. The body's natural network of smaller blood vessels, the collaterals, can sometimes develop over a few weeks to compensate. And we can even use minimally invasive endovascular procedures like balloons or stents to improve flow in the remaining arteries if there are other blockages. This might be an option, say, for a localized infection in the groin part of an aortofemoral graft. We could potentially tie off the affected limb of the graft through a clean incision higher up in the retroperitoneum, remove the infected segment down in the groin wound, and maybe open up any remaining blockages in the arteries above using endovascular techniques.
Okay. So sometimes the body can compensate, or maybe needs a little help. But when a completely new bypass is needed, how is that actually done surgically? The extra anatomic route.
Right. The standard procedure involves completely removing the infected graft and then creating a new bypass through healthy tissue areas that are definitely not infected. This is generally necessary for that GGEF situation, the graft-bowel connection, and for more widespread infections with sepsis or large abscesses.
Makes sense.
For aortoiliofemoral grafts, the ones going from the aorta down to both groins that are infected throughout, we typically need to reopen the abdomen or use an approach from behind the abdominal cavity, the retroperitoneal approach, to remove the entire graft, including the original suture lines.
Right down to the artery.
Exactly. And we always send the removed graft material to the lab to identify the specific bacteria. During the surgery, we might need to temporarily clamp the aorta above the level of the original graft to control bleeding, especially if there's a lot of inflammation. We might also use balloon catheters inside the iliac arteries further down to help control bleeding there. The tubes that carry urine from the kidneys, the ureters, they need to be very carefully identified and protected during the dissection. Sometimes we even place stents in the ureters before surgery if there's kidney swelling due to the infection pushing on them.
Okay.
Lots of surrounding structures to protect. Absolutely. When we close off the aorta and the iliac arteries after removing the infected graft, we use strong, non-absorbable sutures, usually in 2 layers. And we make sure to avoid using any patches made of artificial material there.
Right. Don't want to introduce more foreign material.
Exactly. In rare cases, if the infection extends very high up the aorta near the kidneys, we might even need to sacrifice the origin of a renal artery and then create a new bypass from the aorta above to restore blood flow to that kidney.
Wow.
We also aim to maintain blood flow into at least one artery in the pelvis from the new bypass going down the leg to prevent problems with blood supply to the pelvic organs.
Okay. And after the infected graft is out?
After removing it, we aggressively clean the area, debride it. Sometimes we use a piece of fatty tissue called the omentum, which has its own blood supply, bring it down from the upper abdomen to cover the cut end of the aorta, the aortic stump, and the wound in the retroperitoneum.
Why the omentum?
It's thought to help reduce the risk of further infection of that aortic stump, which can be a devastating complication. We might also place temporary drains and continuously rinse the wound with a dilute antiseptic solution like betadine. Follow-up CT scans can help us monitor whether any remaining abscesses are shrinking.
Okay. And when they do this new bypass, the extra anatomic one, is it always done at the same time as removing the old infected graft?
The timing really depends on how stable the patient is. In patients who are very unstable, severe sepsis, active bleeding, or a graft enteric fistula, we usually do the graft removal and the new bypass surgery in the same operation. One big procedure.
Right. Get it all done.
But in more stable patients, maybe with milder signs of infection, a staged approach can actually be better.
How does that work?
This often involves first placing an axillofemoral bypass, that's a graft that runs under the skin from the armpit area down to the groin artery.
Okay.
And then, maybe a day or two later, performing the second surgery to remove the infected aortic graft from the abdomen.
Why split it up?
This staged approach has actually been shown to have a lower risk of death around the time of surgery, perioperative mortality, in patients who are otherwise stable enough for it.
Interesting.
And over the years, this standard approach to aortic graft infection excision and extra-anatomic bypass has led to better outcomes overall. We've seen fewer early limb losses, fewer infections of the remaining aortic stump, fewer reinfections of the new bypass graft, and improved survival in the medium term.
That's progress.
It is. However, graft enteric fistula and severe sepsis still carry the highest risk of death. And diffuse infections that involve the groin areas, especially if there are significant blockages in the arteries further down the leg, can make these extra anatomic bypasses more difficult. Unfortunately, limb loss is more common after aortofemoral graft infections compared to infections of grafts that only involve the aorta and iliac arteries higher up. Sometimes we might use a bypass that only goes from the armpit to one leg, an axillounifemoral bypass. And it's also important to try and maintain blood flow back into the main artery in the groin, the profunda femoris, maybe by using a patch made from a vein to close it off after removing the infected graft.
Right, preserving that deep thigh flow.
Exactly. Another option for aortofemoral graft infection is maybe place a bypass from the armpit to one leg, combined with a bypass made from the patient's own deep vein running across to the other leg, a venous crossover graft, followed by complete removal of the aortic graft.
Lots of complex plumbing options there.
It can be very complex, yes.
Okay, that's a lot to consider with removal and extra anatomic bypass.
Yeah.
Now let's talk about the other major strategy, replacing the infected graft in its original location. In situ replacement. When is that possible, and what are the different ways that can be done?
Right. Replacing the infected graft right back in its original position, in situ replacement, is becoming a more common strategy, particularly for less aggressive infections. One option is to use the patient's own veins. We call this an autologous graft.
Like the saphenous vein.
Exactly. The long saphenous vein from the leg, or veins from the upper arm, can be used to replace infected grafts in the lower leg, maybe supplying abdominal organs, in the neck, upper arm arteries. However, using the long saphenous vein for larger arteries, like the femoral artery in the groin or the carotid artery in the neck, hasn't had great long-term success. The vein isn't always the right size, it can be a mismatch, and it tends to narrow over time due to intimal proliferation.
Okay, so size matters.
Size and durability. Using segments of the femoropopliteal vein, that's a deeper, larger vein in the thigh, can provide larger diameter grafts and has been more successful for bigger arteries. But we need to carefully map out the veins using ultrasound before surgery to make sure we have a good size match and enough length. We also need to confirm that the femoral vein itself is healthy and large enough to harvest a segment from without causing problems.
Right. Careful planning needed. And we've heard about creating a whole new aortic system from veins. That sounds ambitious. How does that work?
Yeah, the neo-aortoiliac system reconstruction, or NAS, That involves using segments of the superficial femoropopliteal veins, usually from both legs, to actually build a new aorta and iliac arteries after removing the infected aortoiliofemoral graft.
From both legs. Well,
Often, yes. This requires very careful ultrasound mapping of the deep veins in both legs before surgery because you often need quite long lengths of vein. That means harvesting them from both thighs.
big surgery then.
It is. The surgery involves making long incisions in the thighs to remove the veins, and you have to tie off all the smaller branches very carefully. The vein is usually taken from below where the deep femoral artery branches off.
And recovery.
We often recommend giving lower doses of blood thinners after surgery, anticoagulants, and using compression devices on the calves to help with blood drainage from the veins and prevent blood clots in the tied-off vein segments remaining. There's also a bit of a higher risk of a condition called compartment syndrome in the calf, especially in patients who've previously had their long saphenous vein removed, so we need to watch closely for that.
Oh, they use the vein.
The vein segments are usually used in their normal orientation, non-reversed, after turning them inside out temporarily to carefully cut out the valves inside.
No.
Depending on how long the new aorta and iliac arteries need to be and how much vein we actually get, we can tailor the reconstruction. If the original aorta was quite wide, we might use a technique called pantaloon, where we sew two vein segments together side by side to create a wider tube for the aortic connection.
Clever. And how do the results compare?
Well, when we compare in situ replacement with these vein grafts to the traditional approach of removing the graft and doing an extra anatomic bypass, the vein graft approach, the in situ replacement, has generally been linked to lower rates of death and amputation, better long-term graft function or patency, and, importantly, a lower chance of the infection coming back.
That sounds very promising.
It is. Long-term studies, particularly from pioneers like Claggett and his group, have shown really good results with this technique. However,
Always a however.
right. It's not a good option for patients who have that graft enteric fistula, the connection to the bowel, or for infections caused by very aggressive gram-negative bacteria.
Oh.
And also, these vein grafts can sometimes narrow over time, develop stenosis. This seems more likely if the original femoral vein used was small, or if the patient has other conditions like coronary artery disease or is a smoker.
So patient selection is key again.
Absolutely.
Okay, so using the patient's own tissue, autologous grafts, is a great option when possible. What about using artificial grafts, prosthetics, to replace infected grafts in the same location? Is that ever done?
Yes, using prosthetic grafts to replace infected grafts in the same location, in situ prosthetic replacement, is an option in certain carefully selected cases.
But isn't that risky, putting plastic back into an infected field?
It carries risks, yes.
Yeah.
There's a definite risk of the infection returning, maybe somewhere between 10% and 20%.
Mhm.
And often, if it does recur, it's with tougher bugs like gram-negative bacteria or MRSA. This risk has led to a lot of interest in prosthetic grafts that have antibiotics actually attached to them, bonded grafts, to try and improve the outcomes.
Do they work?
Well, we've had some success, for instance, with removing an infected graft and replacing it with a standard PTFE graft, but only for very localized, low-grade infections where a biofilm has formed, mainly caused by S. epidermidis.
Okay, low grade only.
Generally, yes. We've also seen promising results using standard PTFE grafts that have been soaked in the antibiotic rifampin just before implantation, again, mainly for low-grade infections in the aorta and iliac arteries.
Rifampin-soaked grafts.
Oh, right. However, the infection can still come back, especially if the bacteria happen to be resistant to rifampin or if the infection is actually more widespread than it initially seemed.
Okay.
But despite these risks, in some situations, think about maybe frail elderly patients with just a very localized biofilm infection in the lower part of an aortofemoral graft. Replacing just that segment with a prosthetic graft through the groin might be a better, less physiologically stressful option than a huge, complex, extra anatomic bypass surgery.
Right, tailoring it to the patient's overall condition.
Exactly. We have specific criteria we use to decide if a patient might be a good candidate for this approach.
Like what?
Things like the infection appearing late after the original surgery, no signs of widespread illness or sepsis, limited local inflammation, maybe a fluid collection around the graft that hasn't become all thick and incorporated into the surrounding tissue. And often, a gram stain of the fluid might show white blood cells but no bacteria, with a culture potentially growing S. epidermidis later.
So the sneaky infection profile again.
Often, yes. The treatment involves giving antibiotics before surgery, very carefully removing all infected tissue, cutting out the original connections of the graft, thoroughly cleaning the area, using a prosthetic graft soaked in rifampin, making sure to cover it with healthy muscle in the groin or omentum in the abdomen, and then continuing culture-specific antibiotics intravenously for about 6 weeks after surgery. Rifampin-soaked grafts covered with omentum have also been used, cautiously, to treat limited cases of graft enteric fistula.
Okay. And the third option for in situ replacement we mentioned earlier was cryopreserved arterial allografts. What can you tell us about those? Where do they fit in?
Right. Cryopreserved arterial allografts are segments of arteries taken from deceased human donors. They're processed to reduce the risk of the recipient's body rejecting them, and they are commercially available now.
So using someone else's artery?
Essentially, yes. There are specific surgical techniques involved, like tying off all the smaller branches very securely with strong sutures and maybe reinforcing the connections, the anastomoses, with strips of the allograft material itself.
When would you choose this?
Allograft replacement can be a primary option, particularly for infections involving the aorta that supplies blood to the abdominal organs. The visceral aorta, when replacing the graft in its original location, is deemed necessary or preferable.
And the outcomes.
Studies, like pioneering work from Kiefer and others, have shown that while there might be a higher risk of death in the early period after surgery, possibly influenced by other complications or patient factors, the rates of limb loss, reinfection, and survival in the following years seem to compare pretty favorably to other methods of in situ replacement, like the vein grafts.
Okay. Any downsides?
Well, older generations of these allografts were sometimes prone to late complications, like the graft dilating and forming an aneurysm or narrowing down and occluding stenosis. More recent studies using newer generation allografts have shown better outcomes in terms of durability. However, one large study looking specifically at infections in the arteries of the limbs treated with allografts reported less favorable results, particularly higher amputation rates. That's raised some questions about whether they should be used more widely for infections outside the main body cavity.
So maybe better for central aortic infections than peripheral ones.
That seems to be the current thinking, yes. Still evolving.
Okay. We've covered the main surgical options in quite some detail. What supportive measures, the adjuncts, are also crucial in treating these infections successfully?
Right. The surgery is key, but it doesn't work in isolation. Antimicrobial agents, antibiotics, are absolutely essential.
Makes sense.
We always aim to use intravenous antibiotics that are specifically chosen based on the bacteria we identify in cultures and their sensitivities. Tailored therapy.
But what do you start with before you know?
Good question. When we first suspect a graft infection, before the culture results are back, we start with broad-spectrum antibiotics. Something like vancomycin to cover gram-positives, including MRSA, plus maybe piperacillin-tazobactam or cefepime or levofloxacin to cover gram-negatives and Pseudomonas.
Okay. Covering the bases.
Exactly. Adjusting the choice and the dose based on the patient's kidney function, and sometimes monitoring the levels of the drug in their blood.
And once you have the culture?
Then we narrow it down. Biofilm infections caused by S. epidermidis or S. aureus are typically treated with intravenous vancomycin. We've kind of moved away from routinely adding oral or intravenous rifampicin alongside vancomycin because of the risk of the bacteria becoming resistant to rifampicin.
Resistance concerns again.
Always. More severe MRSA infections might require higher doses of daptomycin. For Pseudomonas infections, we often use a combination of different antibiotics based on sensitivities.
How long do patients need by the antibiotics?
Usually for at least 2 weeks. More serious invasive infections might need 6 weeks of IV therapy.
And after they go home?
After the patient goes home, oral antibiotics might be used for another week or two for less severe infections. We rarely use long-term, low-dose oral antibiotics just to suppress the infection indefinitely, though it's sometimes considered in very specific palliative situations.
Okay.
And it's also really important to monitor the treated area with imaging, like CT scans or ultrasound, for up to a year after treatment, just to make sure the infection has completely resolved and isn't coming back.
Long-term follow-up is key.
Absolutely.
You also mentioned antibiotic-loaded beads earlier. How exactly are those used in treatment?
Right. We use PMMA beads, that plastic cement material that are loaded with high concentrations of antibiotics like vancomycin, daptomycin, tobramycin, or gentamicin. We use them as part of the wound sterilization process, primarily in infections outside the main body cavity, like in the groin.
How are they placed?
These beads are actually made during the surgery, mixed with the antibiotic powder, and then placed deep into the infected tissue bed after cleaning it out.
And left there?
Temporarily. Patients typically undergo several more surgeries, maybe every 3 to 4 days, for repeat wound cleaning, washout, removal of the old beads, and placement of new antibiotic beads. A staged approach.
Wow, multiple trips back to the OR.
Often, yes. But in our experience at USF, this approach has led to really high rates of successfully sterilizing the wound. It's helped us to either preserve the original graft or perform in situ reconstruction in basically all cases where we've used it, with good long-term results in terms of wound healing and preventing the infection from coming back.
So aggressive local antibiotic delivery.
Exactly. Very high local concentrations.
And finally, you mentioned using local tissue flaps. What's the role of that in treatment? Bringing healthy tissue in.
Precisely. Moving or rotating healthy tissue that has a good blood supply from nearby areas to cover either preserved grafts or new in situ grafts can be really important.
When is it most needed?
Especially when there isn't enough healthy tissue in the immediate area after debridement, or when there's a large defect in the skin that needs closing. In the abdomen and lower chest, we can use the omentum, that fatty tissue apron from the stomach, bring it down to help cover aortic grafts and reduce the risk of the infection returning, especially infection of the aortic stump.
And in the groin.
In the groin, the sartorius muscle, which runs down the front of the thigh, is the most commonly used flap. It's usually detached at its upper end near the hip and rotated inwards to cover the femoral vessels and the graft. Other muscles in the thigh, like the rectus femoris or gracilis, can also be used.
Does it really help?
We found that using these muscle flaps, even when there might still be some bacteria detectable in the wound cultures after cleaning, can significantly improve outcomes. It provides healthy, vascularized tissue, helps fill dead space, and can really help salvage complex, difficult groin wounds.
Brings in blood supply and immune cells.
Exactly. Promotes healing and helps fight residual infection.
This has been an incredibly detailed look at a very serious complication. Really comprehensive. Before we finish up, is there anything specific about infections of endograft devices, the ones placed through catheters, that we should briefly touch on? Are they different?
Yes, that's a good point. While infections of aortic endografts are still relatively uncommon compared to open surgical grafts,
Yeah.
the number of reported cases is definitely increasing as more endografts are used. About a third of these infections, which can involve endografts in the abdominal or thoracic aorta, can actually present as connections to the bowel or the breathing tubes, the airways, aortoenteric or aortobronchial fistulas.
Why would that happen with an endograft?
It might be due to ongoing inflammation around the aneurysm sac. Maybe endoleaks continued blood flow into the sac, or pressure inside the aneurysm sac pushing the device against adjacent structures. Infection can also occur through the bloodstream seeding the device or by direct contamination during the initial endograft procedure, although that's thought to be less common.
And how are they treated? Same principles.
Generally, yes. The main treatment usually involves complete explantation, removing the endograft, and then performing either an extra anatomic bypass or replacing the graft in its original position using veins, allografts, or maybe antibiotic-treated prosthetic grafts.
Sounds like major surgery again.
It is. And removing an endograft, especially from the aorta, can be technically very challenging and carries a significant risk of death, perhaps even higher than for open graft infections sometimes. The largest study reported so far looked at a multi-center experience. It showed outcomes, including mortality and limb loss, that were broadly comparable to those reported for open surgical repair of aortic graft infections. However, factors like not using antibiotic-treated prosthetic grafts for in situ replacement, having a gram-negative infection, and the presence of a graft-enteric fistula were associated with poorer survival.
Okay. Any other options?
In some very limited cases, maybe an infected pseudoaneurysm or an erosion related to an endograft, minimally invasive endovascular techniques like placing a covered stent might be used as a temporary measure, a bridge, before more definitive open surgery.
And non-surgical treatment?
In very high-risk patients, ones who are perhaps too frail for major surgery, who don't have an obvious connection to the bowel, and who show a rapid clinical improvement with antibiotics. Managing the infection without surgery using long-term antibiotics might be considered, but if the signs of infection, the sepsis, persist, then removing the endograft is really necessary, if at all possible.
Got it. And I understand there's a treatment plan or algorithm at the end of the chapter in Rutherford's that helps guide the management of these infected aortic grafts and endografts.
Yes, that's right. At the end of the chapter, there's a suggested algorithm. It takes into account the patient's clinical condition, like do they have a GGF, What type of bacteria is involved? Are there signs of systemic sepsis? As well as anatomical factors like the location and extent of the infection to help guide the choice between extra anatomic bypass, in situ replacement, or other strategies.
Okay. Well, this has truly been a deep dive into a really challenging area of vascular surgery. It's so clear that managing these infections requires a very thorough understanding of the underlying causes, the specific bacteria involved, and a treatment plan that's really tailored to each individual, often involving a complex combination of surgical techniques and antibiotic therapy.
Absolutely. Early detection and accurate diagnoses are just critical, as we've
Right.
discussed. And the way we treat these infections is constantly evolving, constantly improving, hopefully, with advancements in techniques for replacing grafts in their original location, the in situ methods, and the development of materials that have antibiotics incorporated into them.
So thinking about all this, considering that infection is a potential, albeit maybe low, risk, even after seemingly successful vascular surgery, what are the most important questions you think patients should perhaps ask their surgeons about long-term monitoring and preventative measures related to their specific graft? It's definitely something for you, our listener, to think about and maybe explore further in the resources we've mentioned from Rutherford's. Thank you so much for joining us for this deep dive.